All right, welcome. Today, we're going to dive into something that trips up a lot of us on the wards, really understanding what the pulse is telling us. We're going to clear up the differences between pulse pressure changes and those really tricky double beat pulses so you can feel a lot more confident in your next physical exam. Okay, before we get into the weeds, let's start with the absolute basics. What even is a pulse? Well, it's that wave of pressure you feel, created every single time the left ventricle squeezes and pushes blood out into the arteries. You can almost think of it as the heart's signature, written in pressure with every single beat. So here's our game plan. We'll start with the fundamentals of pulse pressure. Then we'll look at what happens when it goes to the extremes, super high or super low. After that, we'll tackle what I call the double beat dilemma, so you can finally tell the difference between a Bisferiens and a Dicrotic pulse. And we'll wrap it all up with some really practical clinical takeaways. First up, let's talk about pressure. And I'm not just talking about how strong the pulse feels, but the actual range of that pressure wave. Now, the math here is super simple. You just take the top number, your systolic pressure, and subtract the bottom number, your diastolic. But don't let that simplicity fool you. That one little number gives us some powerful diagnostic clues, and we're about to see what it means when it gets way too wide or way too narrow. So let's put these two extremes head to head. On one hand, you could have a wide, almost bounding pulse pressure, and on the other, a really narrow, thready one. What do they actually tell us? It's pretty straightforward when you see it like this. On the left, an increased, or what we call a wide pulse pressure, just means there's a huge gap between the systolic and diastolic numbers. And on the right, a decreased, or narrow pressure, means that gap has shrunk way down, bringing those two numbers uncomfortably close together. The key number you got to remember for an increased pulse pressure is anything greater than 50 millimeters of mercury. When you do that subtraction and you get a number that big, your clinical alarm bells should definitely start to ring. So what's behind this? Well, the main reason is often a big stroke volume combined with a really fast drop in pressure during diastole. The textbook cause is aortic regurgitation, right? Blood is leaking back into the ventricle, so the diastolic pressure just plummets. But you also see this in high output states like a fever, hyperthyroidism, or even an AV fistula, that abnormal connection between an artery and a vein. All of these things just widen that pressure gap. Now on the flip side, we have decreased or narrow pulse pressure. And the criticate number here is less than 20 millimeters of mercury. A gap that small tells you the heart's stroke volume is very low. It's just not pushing much blood out with each beat. And the causes here are really serious. The classic example that should always be on your mind is cardiac tamponade, where fluid is literally squeezing the heart, stopping it from filling and pumping right. You can also see it in severe low output states like hypothyroidism. Seeing a narrow pulse pressure is a huge red flag. Okay, so we're shifting gears now. We've talked about the size of the pulse wave, but now let's get into its shape. This is where things can get really confusing. What does it actually mean when you feel 2 beats for every one you expect? This is the exact question that can stump you during an exam. You feel that thump, where you're expecting just a single thump. You know it's not normal, but it could mean one of 2 very different things. So how in the world do you figure out which one it is? Well, the answer comes down to telling the difference between a Pulsus Bisferiens and a Dicrotic pulse. They both feel like a double beat, but what's happening inside the body is totally different. And the key is understanding one incredibly simple rule about their timing. It all comes down to timing. It's that simple. In Pulsus Bisferiens, both of the peaks you feel are happening during systole, one after the other. It's often seen in conditions like HOCM, Hypertrophic Obstructive Cardiomyopathy, but you can also feel it sometimes with a high fever or after intense exercise. Now, with a Dicrotic pulse, you feel one peak in systole, and the second, smaller peak, happens in diastole. This is a bad sign, usually associated with severe heart failure, like in dilated cardiomyopathy or sepsis. Let's just boil this down because it's so important. If you remember absolutely nothing else, remember this one rule. To tell these 2 pulses apart, you just have to ask yourself, where does that second beat fall? If it's in systole, it's Bisferiens. If it's in diastole, it's Dicrotic. That's it. That is the whole game right there. Okay, we've covered the pressure extremes, we've solved the double beat dilemma. Now let's pull it all together into a really practical framework that you can actually use to connect what you're feeling to what might be going on with your patient. Think of it like this, a simple 3-step process at the bedside. Step 1, assess the pulse pressure. Is it wide or is it narrow? Step 2, feel the shape. Is there a double beat? And if there is, time that second beat. Is it systolic or diastolic? And finally, step 3, use those 2 pieces of information to connect to a likely diagnosis. And here's your rapid-fire cheat sheet. If you feel a wide pressure, greater than 50, you should be thinking aortic regurgitation. If you feel a narrow pressure, less than 20, your mind needs to immediately go to cardiac tamponade. If you feel that double systolic beat, Pulsus Bisferiens, think HOCM. And if you feel that Systolic-Diastolic double beat, the Dicrotic pulse, think severe heart failure, like a dilated cardiomyopathy or sepsis. These are your high-yield links. So the next time you put your fingers on a patient's pulse, don't just count the rate. Really feel it. Feel for the pressure. Is it wide? Is it narrow? Feel for the shape. Is there a second beat? And if there is, when does it fall? Because answering those questions, well, that's the key to turning a routine part of the physical exam into a moment of real diagnostic insight.